Let me have. Yeah, Datta's joining as well in a minute. He just messaged.
Ma'am, you are going live on YouTube. It's already done. So we are live on YouTube and Facebook. I am YouTube channel.
I think Dr. Call's not going to be here. He mailed me sometime later saying that he had forgotten that he's aboard a flight at this time. He had mistaken his schedule. So that's okay. We've got others. So I think I can turn off my video for now. Let ma'am's video be on. I'll turn off mine. So I see 16 people in the participants list. So we've got the four of us. Why is Datta not joined in yet? He should be in. We've got attendees. Yeah. So there's a
Sir,
fair
you
number.
can start.
So I think Dr. Devashish is not joining, right?
Yes.
So ma'am, we could start.
Can't see everybody. Okay.
We could start.
Okay. Good evening, everyone. And I think it's enlightening to see some people joining us on this first webinar of the sleep subsection for the Indian Academy of Neurology. And we look forward to having many more. And we would also like at the end of this to get some suggestions on the way to go forward and other people to join in and partner to take this forward. So we were hoping to have the president, IN president with us, but I think because we want to stick to our time and also allow a lot more time for discussion, so maybe we should start with the program. So the plan is that I'm going to just present a case, something like what we all see in our day-to-day practice. We can open it up for discussion following the case. People can have, it's a very informal kind of a thing. So anybody has any comments can just keep them together and we can answer that at the end of the case presentation. Then Dr. Joy will present a case. We will have some more discussion. And the last part, we would like some inputs on what is the vision and the plan and how to take this subsection forward. So without wasting any more time, I'm just going to try and share my screen and so let me start with this case. This is a lady. She is, let's call her Mrs. S. She's a 58 years old lady. So what did she come with the complaint of? She came that, you know, she's now 58, but she says that maybe 10 years, maybe 15 years, she's been suffering from this entity called as poor sleep. And if we go a little deeper into the history, the first question we ask is, of course, duration. Then we ask, how long has the problem been? And what is the type of the problem? Is it difficulty in falling asleep? Is it difficulty in maintaining sleep? Is it just waking up too early, not being able to go back to sleep. So she said she had both now. She doesn't remember really clearly how it started, whether it was probably sleep onset, but she has difficulty in falling asleep and she has difficulty in maintaining sleep. And what about the day? So day, she's perpetually tired. She has a lot of headaches, body aches, decreased interest in most of the things, prefers to be alone, less motivation. So these are the kind of daytime symptoms. What has she done for this so far? So initially, she started by taking zolpidem, which was intermittent, as they all call it, maybe once in a few months, then few weeks, then few days in a week, and then became regular. And I will show you the chart that she's on now. And she kept increasing the medications because she felt that I'm not being able to sleep the way I want to sleep. We have another interesting thing for people who are new to the sleep history. We can have separate sessions on how to take a history for a patient with sleep, but this is, I'm just going to condense this in this case. So first we ask about her chief complaint, but then we have something called as a 24-hour history for sleep patients. What we mean is that we go right from their bedtime through the night and through the day to understand what is it that we can do to help them get a good night. So we start with the bedtime. So this is, she goes into bed at about 10:30, 11, and she starts waiting for sleep. She takes all her medications, which I will just share with you. And in addition, now she's recently added a CBD oil at around 12. She's not sure when she falls asleep. She watches TV or she keeps looking at the time and her phone continuously. In the morning, she surfaces at around maybe 9, 10, but finally gets out of bed by noon. Most of the day she's lying down because she feels that I don't have energy to get up and do anything. She has breakfast in bed. For lunch, maybe she moves out, sits in the living room a bit. There is no regular physical activity. Dinner is variable. So this is what we mean when we say that she does the whole day and night routine that we want. What are the current medications? She's on now clonazepam 2 milligram, trazodone 100, pregabalin twice a day, melatonin about 5 milligram, olanzapine, quetiapine, and some others. So this is her background, and she still feels that I'm not able to sleep. She denied any other really systemic complaints. She denied any stressors at the moment, and she said everything else is kind of okay. Only please help me with my sleep. Examination revealed her BMI to be about 28. She appeared really very dull, very lethargic. She came with her daughter, and the daughter was continuously checking and saying that, she's in bed most of the day and mostly on her phone. Other thing in examination revealed that she had this melompathy, which is grade 4. So melompathy, for people who are not aware of this is a grading that we do when we see the airway. Ideally, we are supposed to see the complete palate, the uvula, the tonsillar pillars, the tonsillar fossa, and the posterior pharyngeal wall. That is the ideal one. And then you have grades of that's 1, 2, 3, and 4, depending upon what can we see. So the last one is the grade 4, where the palate is almost just sitting on the tongue. You don't see any tonsillar pillars. You don't see any tonsillar fossa. And she had something like this. The chest examination, neurological examination was otherwise all right. Her baseline oxygen saturation was 96%. So this is where we are. And the question was that what do we do now? If anybody we have about a few minutes. So I think people, if they have anything to ask, we can address those questions, or people can write in the chat box and ask, or how do they ask?
Yes, the best methodology is to write in the chat box so that there is an organization.
If anybody has any 1 or 2 questions, then we can do it like a differential. So what else would you like to do or know in her case? So her, again, I'm just emphasizing that her main issue is that I can't sleep. She's on these many medications, but still she can't sleep. So what would we like to know more in her history? Okay, so some So somebody is suggesting that maybe we should do a sleep study and look for sleep apnea. Any snoring? So she sleeps alone. The daughter said that when I do sometimes sleep with her, there is some kind of a noise which comes. There is maybe some snoring. Her BMI was about 28. Timing of the medicine that she takes them starting after dinner and she goes on. And sometimes she even wakes up at night and takes a few more. Caffeine intake at night, she doesn't take. Psychiatry history, so far nothing, but she's met a few people and, physicians who've all given her this, but she denies, as most of them do, that she has any major illness. So I think we've got some inputs now. So we will go forward with the case. What do we do? So when an individual comes and says that I'm not able to fall asleep or stay asleep, yes, we do start thinking of all this. What are her habits like? Any medications that she's on which are harmful? Any pain-related issues? Any neurological conditions, dementia, early cognitive impairments, Parkinson's, psychiatric history, whether she has anxiety, depression, bipolar. And yes, we should keep an option and try and look for primary sleep disorders. So by primary sleep disorders, we mean whether she has a sleep apnea or restless leg syndrome or anything else like that. And yes, some people have rightly said that, her BMI was suggestive. And we said, okay, that let's try and do a sleep study. So just a point here that which kind of patients with chronic insomnia would we do a sleep study? So sleep study ideally is not recommended by the American Academy for evaluation of a patient with insomnia, but except for these few conditions. Number one being that if there is a suspicion of sleep apnea, definitely it should be looked at. If there is a suspicion of any other sleep disorder like PLMD or PLMW, they should be looked at. Third is chronic insomnia, absolutely unresponsive, and we are not able to get a headway. So in any of this, so she does fit that there should be two requirements, and we plan a sleep study. So what did her sleep study show? I'm just going to show the hypnogram. So again, for people who are new to this whole chart is called as a hypnogram. It means that it is a snapshot of the whole night. And for people who are new to this, we have the numerous channels that we record on the extreme left. And this is how it goes. So this first one here is the oxygen saturation, the heart rate, and these red ones are the apneic events. And then we have the sleep stages, and we have desaturation, snoring, heart rate drop, body position, etc. So what did we find? We found that in the initial 2 hours of sleep, definitely desaturation, and she had a significant amount of apneic events. And so thus, she had definitely the complaints of insomnia, but she had this entity which was sleep apnea. And this was a split night study. And as we can see that after the PAP, the saturation was very good, apneas were controlled, and she had a very good REM rebound. So this lady then finally, so what did she, biochemical normal, and her sleep at 64, and we know that more than 30 is severe. So what was her follow-up? So follow-up, yes, we meet these people and we try and tell them that this is, you have another entity, which is obstructive sleep apnea, in addition to your problem, and you will need to take a PAP therapy. And we suggested her some other measures for the sleep hygiene and her day-to-day routine. But as expected, and which we will discuss in another few minutes, she was not really very comfortable with the PAP, and this is her scenario. So this is some for people who want to go through this. This is a good resource to have. This was the consensus which we did with the Association of Physicians of India, with the Indian Society for Sleep Research, with senior faculty, and it was published. So what was really the crux of this is that when we see a patient with chronic insomnia, history forms the major background that what is the patient's problem, and we try and tease out that what could be the cause of this insomnia. The physical examination, mental examination will give you some more clues, and then we do a sleep study. So I'm not going to go over this chart. This chart is there in that book, but basically these were algorithms for evaluation and diagnosis of insomnia. First and foremost, look at their sleep habits and an adequate opportunity. So insomnia, yes or no. If yes, is it acute or short term? That means less than 3 months. And is it chronic? That means more than 3 months. If more than 3 months, is it a psychiatric problem? Is it any medical problem or sleep? So I think when we think or when we are seeing or face with a patient with a chronic insomnia, please keep in mind all the entities which could be causing insomnia and not be in a hurry to switch the medication or add another tablet, because that's not going to be the answer. Because on the face of it, this patient had a clear-cut chronic insomnia, maybe comorbidity, maybe some anxiety, depression, but it was never thought that she could be suffering from this entity of a sleep apnea. So what about treatment for these conditions? This again, algorithm is there. Acute short term, yes, focus on their stressors. Maybe you can give the Z drugs for just a few days and they should resolve. Chronic are the ones when we are having a problem, that what kind of treatment to give, which medication, how long, and the role of CBTI. So I think all guidelines, I'm not listing them here, but the American Academy, the Association of Physicians of America, and the National Health Foundation, they've all recommended CBTI as the primary treatment. But if CBTI, of course, is has its own limitations, not easily available, it's expensive and time consuming, results take a little time, then you can add the drugs. And we had the benzodiazepines, we had Z drugs, and now we have the DORAs. So what are DORAs? This is the dual orexin receptor antagonists, basically working on the genetic mechanism that there is a hyperarousal. So they work on that arousal mechanism and work on the orexin so as to induce sleep. So I will end here, I think, and we can take up some thoughts from people, and I will talk about this entity called COMISA after some people have, again, put in some thoughts. So this is just to show you that all the different types of sleep disorders, which are the ICSD-3, but we can have combinations. And in the future, we will show you some more combinations and which are getting very difficult to diagnose and manage. So I'll take a break for a few minutes. If people have to say anything or write anything, then we can discuss those. And how would you, going forward, manage this patient? And what do you think is the final diagnosis? We can again maybe write in the chat box. She didn't act out her dreams. I missed that question earlier.
So, now this is the open time now. So if somebody wants to share their thoughts, you could just put it in the chat box and say that I want to say a few things, and I'm sure the host will allow you to be part of the chat. So it's Datta or anybody else.
Otherwise, then I will just finish in a few more minutes the entity, this COMISA.
Yeah. Datta, you have any thoughts on what ma'am showed you just now?
Actually, I joined it late. I missed the initial part of the history. But I think so this case illustrates the importance of taking a good history in this case, and the importance of doing polysomnography in selected cases of insomnia. Not all cases of insomnia require this, but this is a case where it illustrates the importance of polysomnia in selected case of doing a polysomnography in selected case of insomnia. So I missed the initial part of the history presentation.
Basically, a 58 years old lady with chronic insomnia for maybe 15 years and on multiple polypharmacy drug therapy now.
Okay.
And still not sleeping.
Okay. So I think this one of the reason of her insomnia could be this obstructive sleep apnea, which is treated, but still the patient has complaining of this maybe associated comorbidities in patients with insomnia needs to be treated. I think we need to really go into the history again, and other comorbid factors like psychosocial factors or other things.
Yeah. So I'll just briefly take maybe 3-4 minutes more. So the case, the reason for presenting the case was one, that these people come to us really far burnt out in their journey of this chronic insomnia. They've tried everything, it's all failing. Quality of life is extremely poor. So how do we help them? And when do we recommend or advise a proper sleep study? So this entity is called comorbid insomnia and sleep apnea. It's a good new terminology, not so new. It was, see, if I show you this chart below, it was talked about by Dr. Gillimano in almost 1973, because he found these patients who had sleep apnea and had insomnia. Then for many years, sorry, it didn't attract much attention. Then after 99, you see it has considerably gone up. So the numbers of reports, publications has gone up considerably. Why? Because people started noticing that this, and there are two disorders which can exist in the same patient. And why are they important? And they have certain recommendations. And they said almost 30 to 50% will have these symptoms. And this could be one factor when some of our patients who are failing CPAP with reduced acceptance could be because they have insomnia. And I have seen a lot in my clinical practice that people who are being told to use a CPAP, but we have not asked them about insomnia, they will not be able to use it, especially the CPAP onset insomnia. So this could be one reason for the CPAP failure. Then came another article. These, people can go through these articles. They are really nicely described. And again, the same thing they said, that there is a high prevalence of insomnia symptoms in patients with OSA up to the tune of 40 to 60%. So this combined entity needs a multidisciplinary approach and a proper treatment, and then only you will be able to get better results rather than offering a single treatment. So that's the thing about this COMISA. So how does one recognize this, and what is the impact, and who's at risk? So females are known to be at a much higher risk. People with chronic pain, lot of nocturnal restlessness and kicking. And what is the impact? It's been shown that this, firstly, it has a lot of pain components. So the people who have this, their pain components are much higher than anybody who has insomnia alone or sleep apnea alone. Musculoskeletal pain. A lot of my patients I've seen have been diagnosed as fibromyalgia. So the threshold for pickup has to be low. So a female, not really very obese, severe insomnia, lots of body pains, fatigue, tiredness in the day, keep thinking that is there a obstructive sleep apnea or a COMISA. What are the kinds of insomnia problems they can have? Bulk of them will have maintenance insomnia, and of course then some of them will have a initial insomnia, and some may not have. So this is, you have to pick them up. Why are they important to diagnose? This again I've mentioned, but some of them will have symptoms which are common to insomnia and to sleep apnea. So both can run together. So both have decreased quality of life. They are sleepy in the day. Attention concentration is bad. Night is very bad. Frequent awakenings, difficulty in falling asleep, fatigue, mood disturbances, etc. So why does it occur? Dr. Arun was saying something like this. So what happens is that sleep apnea can cause fragmentation of sleep and cause arousals, so that they can come with what is called a sleep maintenance insomnia. And this is how women are presenting, that they will come and say that my sleep quality is not good. I wake up a lot. And this could be one reason. And of course, then they have nocturia, the people with sleep apnea, and that can also be a reason to break their sleep. And the other way around, in insomnia, there is an activation of this HPA axis. So both start running together, and these people are at a greater risk for metabolic syndrome, cardiovascular consequences. So they have to be picked up and treated. How to approach them? A very comprehensive approach, as we've already mentioned, history and a sleep study to be done. A complete evaluation is needed, and how to treat them. Again, a multidisciplinary approach. So treatment of both the disorders. So we think of CBTI, we think of positive airway pressure, and you think of sleep hygiene education and medications. So for these people, the threshold, like I said, lower, and treatment has to be multidimensional. So just to conclude, the association between insomnia and OSA is an important association, still needs a lot of depth and study, but requires a multidisciplinary approach and the treatment of both entities. So there's a lot of work going on. Should you treat CBTI first? Should you treat PAP first? Should you treat both together? That's where this is quite a challenge. And of course, look, especially people, when you have sleep apnea alone or insomnia, symptoms persisting is when we need to think that we should look for this entity. And I'm going to just end here and just request all of you to save this date. We will be having a big sleep meeting next year, February, and you will get more information from us slowly. So I'm ending my presentation here. We can take question answers or any comments that people want to say.
Yeah, that was very nicely done. And I think your message is very loud and clear that we need to be sensitized to ask our patients when they tell us what they think is the problem about the multifarious ways in which the roadmap to sleep harmony can get disrupted. So if we take the story with due diligence, then the likelihood of missing this is lowered. And many a time, I think one of the things in India is that patients don't talk about how they sleep and how they feel. I mean, the symptoms that you narrated, she lies in bed all the time. She doesn't have energy to get up and do things. Now, this is taken for granted that it is just me, and it is not thought of as something that needs addressing. So it may sound very non-specific, but the amount of immense lethargy that they have, and your first slide very eloquently and clearly showed that she was so lethargic that despite sleeping at 10:30, she would not get out of bed till 10:12, and she would do most of her breakfast lying down in bed. So that itself was a kind of first red flag that what's
Yeah.
going on here.
So also then I was trying to highlight that history, that when we intervene with suggestions to these patients, we have to kind of intervene at small doses to how to help them to get out of bed, because the more they stay out of bed, the more they will build their sleep drive. And of course, if they are taking so many sedatives at night, they're bound to stay in the body the whole day and make them more lethargic. I'll just answer these 2-3 questions people have put up. So one is requesting for details of DORAs. I think we will maybe do that some other day and completely talk about the neuromedical therapy. But just now to summarize briefly, that orexin is secreted from the hypothalamus, and it was first discovered or diagnosed, or research showed that it has a very strong role to play in narcolepsy. That means when orexin goes down, people are very sleepy. So if we were to antagonize the orexin, you would kind of keep people, make them fall asleep. And that's how this research kind of came about the DORAs. There are numerous DORAs which have been approved by the US FDA. And in India, we have the lemborexant, which has its own issues, but that's the current one which is available. Chronic insomnia with OSA, what are the indications for imaging of the brain in such cases? See, I don't think we have any clear-cut guidelines on when to do imaging of the brain. I mean, unless you are suspecting a neurological disorder, like somebody comes to you with associated tremor, rigidity, some slowness, and you're looking for something, then maybe. But just by itself, a healthy person, we don't really do imaging. Slow wave sleep pattern changes in chronic insomnia, any heart rate variability in PST. Yes. These people have that there is a change in the deep sleep pattern as you go through these areas, and that is what is called as a change in sleep architecture. So these people will or may have a decreased slow wave sleep, and they have more of a sympathetic arousal, so their heart rate variability can be observed. In fact, there are now some AI-based tools which are assessing the HRV in these people and showing a sympathetic arousal. Any other questions which are there? Okay, how to pursue sleep fellowship for neurologists, we'll talk about later. Is there a slow wave pattern improved with treatment? So the medications, if you look at all the, started with barbiturates, benzodiazepines, melatonin, Z drugs, the melatonin agonists, and antihistamines, and now the DORAs, they all have some role to play on the sleep architecture. But all the benzos and Z drugs, the issue was that they were decreasing the REM sleep and also not really helping much with the slow wave. Whereas the DORAs now are shown or seem to maybe increase REM, so they are slightly better. If AHI is borderline, how to differentiate between COMISA and delayed sleep phase disorder? So see, borderline, so either AHI is normal or abnormal. So that's one part. So either we commit that is there sleep apnea, yes or no. How to differentiate between COMISA and delayed sleep. So delayed sleep phase disorder is the whole cycle has shifted. That means instead of having a sleep onset at 10, 11, they will sleep later and they will also wake up later. But their sleep maintenance is okay. And they wake up, they're okay. They're getting their 8 or 9 hours, whatever hours. So they have, it can be confused with a sleep onset insomnia, because both this group of people, delayed sleep phase and sleep onset insomnia, will both say that I'm not able to fall asleep. That's why it's important to ask them what time are they waking up. Hypersomnia. I think we'll talk about hypersomnia, because we'll go off the topic here. Hypersomnia, we can talk about an anti-MA antibodies. Definitely, we'll take up some cases next time for hypersomnia and then discuss, all that. Let's try and, otherwise we'll go all over the place. And Joy will present the second case. And so Madhuri, next time we will talk about the hypersomnia. Okay. Sorry, this will become very too long, the answers. So Joy, you want to present your case?
Yes.
If anybody else has any comments.
Let me share my screen. Okay, is my screen visible?
Yeah.
Super. Great. So we've got that. And so let's change gears a bit. And most of us are adult neurologists to start with who are now waking up to the fact that sleep's relevant. Maybe we can look at it from that angle as well. So this is a patient. He's a 55-year-old man who was admitted into a hospital in Mumbai, Bhatia Hospital, under somebody else, under a physician, in the 3rd week of June last year, with a history of right-sided weakness without any speech dysfunction, and it occurred on awakening. And the medical antecedents were the following. He had hypertension, which was inadequately controlled despite being on 3 antihypertensive drugs being given by his physician. He was hypothyroid, regulated with oral thyroxine replacement, and he was on a regular statin use with 1 aspirin since 2018. And when he came for the second opinion, when I asked him why, he said that he had developed a brief facial weakness on the right side in 2018, which was attributed to a lacunar infarction after an MRI, but he could not trace the MRI and had lost that MRI, so we didn't have objective evidence of what it was at the time. So he was already on ecosprin, he was already on statin, and he was on antihypertensive medications when he developed this right hemiparesis. He confessed to being sedentary. He chewed tobacco infrequently. He owns a stationery shop in Mumbai, and sometimes he was surreptitiously doing that despite having been told by his physician and his family that it was not good for him. So he was still chewing tobacco when he had this stroke. He was not within the window for thrombolysis on the stroke timeline. And at Bhatia, when he was admitted, his blood pressure was 170 by 100. There was no aphasia or dysphagia, despite the moderately severe hemiparesis. The physician who saw him later got a carotid Doppler done and an ECG and an echocardiogram, and all of which were reported normal for age. His homocysteine levels were high, so the physician put him on vitamin B12 supplementation after the plasma homocysteine had been done. And since he was already on aspirin, clopidogrel was added and he was advised physiotherapy. An MRI of the brain was done at this juncture since he'd had the second stroke. And let's have a look at what the MRI showed. So you can see here that in the left paraventricular deep white matter on the DWI, there is a fresh infarct, and you can see it better here on the left side. And you can see that if you look closely at the images on both sides in the deep white matter, there are now hyperintensities that are visible bilaterally, though he is symptomatic for the left hemisphere. So if one looks at the flare image, this is the coronal flare image of the patient, so MRI, and you can clearly see that not only is the left hemisphere deep white matter showing evidence of the new infarct, but there is a substantial white matter hyperintensity on the right side too. And why we know that it's on flare imaging often that these abnormalities become more dramatically visible to the naked eye when viewing the MRI images. Whereas if one looked at his T2 weighted images of the brain, then they did show deep white matter scattered hyperintensities both in the centrum semiovale in the lower panel and in the basal ganglia, uh, giving an appearance of what one could sometimes construe as cribriform change in the basal ganglia. You can see in the images in the middle and the images on the right that there are holes in the basal ganglia. Now, in conjunction with this, this is the image of his MRI scan angiogram, which is the TOF angiogram. Later, a contrast angiogram was also done. And you can see that the MR angiogram does not reveal any major significant proximal large vessel stenosis, either in the carotid tree nor in the vertebrobasilar system. And so here was the evolution. With these measures, he kind of improved a bit. He was discharged by the physician after 6 days, by which time he could walk with minimal aid. But his problem in his mind, he couldn't, and his family's mind, was that some questions had not been answered. He had persistent hypertension despite 3 medications. He had had these small vessel strokes despite antiplatelet therapy and statins since 18. Was it just the B12? That was the question. And he was seeking secondary opinions, and that's how he landed up at Jaslok Hospital, where I work, and that's where I saw him. And a sleep history was not part of the stroke assessment at all till this time. And now, when we took his sleep history, this patient weighed 85, his BMI was 28. He snored loudly in his sleep since youth, and he considered it being a Gujarati an index of deep sleep, which is something I hear very often from many of my Gujarati patients. He confessed to finding it difficult to be energetic in the morning hours. This was on leading questioning. He affirmed that he did doze off when traveling by train in the suburban trains. And on being questioned, he did say that he felt lethargic after meals. So you can understand that if one takes a specific driven questionnaire to ask about the surrogate signs of daytime dysfunction that can be associated with sleep disordered breathing, he came through very well. And as he himself said, he had no real interest in exercise. And when I asked him to get a level 2 sleep study done, he disappeared, but he surfaced later with a level 3 study done when he had seen one more physician after me and who had read my notes and got the study done. So you can see here that on the study, he had significant number of obstructive apneas, 174, 76 hypopneas with an apnea hypopnea index of 29 per hour. And the longest of his obstructive apneas was 29 seconds, hypopnea 58, and the desaturation index was 24 per hour. And you know that it's substantial enough to warrant attention. His lowest saturation was 83%. So what's the relationship? Is it just something else that exists in this man who is seeking help for small vessel stroke, or does sleep disordered breathing have some association and perhaps putative causality with the occurrence of small vessel strokes in the brain. So this is a study from Greece by Dimitrios Raptis and his colleagues. Not a very large study. They had 24 patients with moderate and severe sleep apnea, and they compared them to 34 healthy volunteers and tried to see whether there was an independent significant association between sleep disordered breathing and small vessel disease. And that's what came through. I think this was one of our student theses there at the medical school. There have been other larger studies. This is a study from Korea, from which was called the Human Genomic Study from the Korea University College of Medicine. And they took individuals aged between 50 and 79 as a part of their assessment, and they underwent imaging of the brain and health screening and polysomnography. And if one looked at the findings on MRI, like in our patient, then in the basal ganglia, sleep apnea was associated with an increase in the odds ratio for silent infarcts and lacunar infarcts across all the apneic individuals who are greater than 65 years of age. And we also have some independent community-based evidence that tells us that perhaps one should think about this. And this is a study from Ecuador, which I have shared in other platforms earlier. A study by Oscar Del Bruto. Many of you might know him. He's done a lot of seminal work on cysticercosis from Ecuador. He looked at the Inca Indians who live in the Inca reserves in the mountains in Ecuador and in the Andes Mountains. And these were 104 randomly selected individuals. And they were assessed for their cardiovascular and lifestyle-related risk factors and a questionnaire for sleep. And they underwent PSGs and MRIs of the brain. And in a regression model, they could confirm that there was an independent association between moderate and severe sleep apnea and white matter change on the MRI. In fact, 22.7% of the patients who had severe OSA had silent lacunar infarcts, had never had symptoms. So one of the statements that they made at the end of the study, and there were 2 or 3 editorializations that came with this publication, it's really something worth reading and pondering on, is that moderate and severe sleep apnea attributes about 4 times a likelihood of having subcortical damage of vascular origin, independent of the other demographics of obesity, hypertension, or cardiovascular risk factors. And we do know now that in the stroke world, wake-up strokes are being associated with sleep disordered breathing. We also know that REM sleep is also a determinant of white matter integrity in some of the studies, like the one shown here. And in a very provocative and very thoughtful evaluation, in one small study, serum from elderly sleep apneic patients was used and in a petri dish model of blood-brain barrier permeability. And you can see here that when compared to controls, if they had severe sleep apnea, their blood-brain permeability was quite grossly abnormal. And we know that that's one of the mechanisms that can contribute to white matter centrum semi-ovale infarcts and hyperintensities on MRI. And in the basic science bench research world, this is being attributed to an elevation in matrix metalloproteinases, namely matrix metalloproteinase 9. So here's the study from Japan, again looking at matrix metalloproteinase 9 levels in individuals with OSA compared to normal controls. And lo and behold, such is the case. So we now have some kind of biochemical and molecular biology explanation for why this could happen. I think for neurologists, one of the other tenets and facets of sleep disordered breathing that comes through is that even hemorrhagic transformation seems to be in stroke more common, and early deterioration with catastrophic edema after a ischemic infarct is more common amongst patients who have sleep apnea. And this has led to many thoughtful articles being written on the complex relationship between sleep and stroke, the one above saying that opening eyes to current knowledge. And we now know that sleep disordered breathing is associated with early deterioration after stroke. Having said that, there are others like this group from Switzerland who've also kind of pointed out that it's a two-way relationship that can happen. Sleep disordered breathing can individually, as shown in the box on the left, predispose an individual to a greater risk of stroke, and at the same time, the depending on the strategic location of a stroke by itself can then go on to alter the neural architecture of sleep harmony and can induce changes in control of breathing, sleep fragmentation, airway collapsibility, and craniofacial motor weakness, depending on where in the neuraxis the stroke has occurred. So I think the take-home message that I wanted to bring about today is that we are understanding, different perspective now, the possible causal relationships between cerebral small vessel disease and sleep disordered breathing. In patients with wake-up stroke, this may have be of a greater magnitude, and it's something that we ought to study. And we now know that there are many individuals who may not have severe total sleep apnea, but may have very severe sleep apnea in their REM sleep. And that itself could be a harbinger of white matter health. So, one of the things that we ought to, as neurologists, we ought to be concerned about is that sleep disordered breathing is a potentially modifiable risk factor that can mitigate stroke risk amongst the other factors that we try and ameliorate, and this should be considered a standard part of our stroke evaluation, both on history and in carefully selected patients after the algorithm has been executed in carefully selected patients with polysomnograms, and in order to understand how we can help these unfortunate individuals bring their health back. So we need to make sleep a priority. And that's my last slide. I'm going to stop here and maybe stop sharing. And this could be opened up for discussion amongst many of my other neurology colleagues who are here. I think there are about 41 participants now. Tarun is here. Tarun, you have thoughts on stroke, sleep disordered breathing, this funny bloke?
Thank you, Joy. And I think it was a very wonderful presentation on the relationship between the sleep disorder breathing, which you showed, and occurrence of small vessel disease. So as we know, this small vessel disease includes everything. It includes white matter hyperintensities, the lacunes, dilated perivascular spaces, and microbleeds. And it has been shown now that it's the hypoxemia per se, which is responsible for these variety of changes, the lacunes as well as the white matter changes. So the AHI, which everyone speaks of, is not the holy grail. And what has been studied is the amount of hypoxemia which is occurring. So the oxygen desaturation index, or how many times did the oxygen drop below 80%, or say how long was the oxygenation less in the night on a polysomnogram, would be a better correlate. There was a study, I think, in the frontiers by Liu et al. From China, which suggested that it's the low oxygenation rather than the number of times of apneas or hypopneas. Of course, that would be important, but I think I wanted to point out that we must pay attention to the desaturation index also. And as you have illustrated very well, we know that these white matter hyperintensities, they occur both in strokes as well as with people with cognitive impairment, the dementias. So there is a common associate between OSA in stroke as well as in dementia, and there is a need to correct it by either whatever therapies we choose, either the CPAP or whatever, at a timely intervention, so that we prevent the recurrence. In your presentation, it was very well illustrated that the patient's blood pressure was refractory to 3 medication. That itself is a red flag that something is going on, why it is not responding. So in such patients, if you do a 24-hour ambulatory blood pressure monitoring, you will find that they are non-dippers. Their blood pressure, which normally should come down by 10% during sleep, it does not come down, and paradoxically, sometimes it may rise. So I think it is mandatory for all of these patients who are resistant hypertension to be looked on very carefully if we are missing out a secondary cause like an OSA. As in your question, it's a very important risk factor. I think a very well illustrated case, Joy.
Thank you. Somebody else has asked the question that in the chat box that is treating sleep apnea, will it relieve the small vessel disease? So that's an important question that physicians like us should think about. And one could look at the perspective from different angles. So I look at it from a very even a broader angle, that if I know that a person has sleep apnea, and we know that sleep apnea confers a 3 to 4 times higher risk of having a vascular event, whether it's in the heart or in the brain, why would I not counsel, advocate, and encourage that patient to take all those measures that can regulate sleep apnea? Put in measures for sleep hygiene, inculcate exercise, and when needed, use CPAP as a modality of treating severe sleep apnea, knowing that this can reverse. One of the things that is the angular response to that question is that there is a lot of interest from Japan and Korea in looking at white matter hyperintensities in middle-aged individuals, and various types of study have been done. In one such study, the Castronovo study, which I have not quoted here, but I presented it in one of the other presentations, is that yes, in some people, using CPAP for sleep disordered breathing can result in a regression of white matter changes visualized on MRI. Since this awareness is not very well known, obviously there aren't other larger studies that have been done. But my guess is if we screen our patients more carefully, then there will be individuals where there may be a remedial change. Again, it depends on what time in the evolution of the persistence of sleep disordered breathing that we intervene. So many of our patients come to us pretty late. So if it's very late, I don't know what is the point beyond no return. So we don't have a good answer to that. So obviously, if we are going to make any inroads to something like this, we as neurologists dealing with general neurology problems need to bear in mind that sleep questioning and taking a history and understanding the sleeping patterns of our patients should be part of every individual that we assess. I think that should be our goal.
Joy, I want to add a little bit on that.
Yeah.
See, this question is a very poignant question, and any meeting you go, this question keeps on coming back to us. That the naysayers, they say there has been the SAFE study. The quote is the SAFE study. They say that the SAFE study showed that in 2,300 odd patients, you gave CPAP and the usual treatment, and the CPAP did not score well over the usual treatment in preventing future strokes. Now, that's the end of it. It's not the end. You need to look at the paper. The papers they excluded patients with excessive daytime somnolence. Most of the OSA patients would have excessive daytime somnolence, and in that paper, all patients who had an Epworth score more than 15 were excluded. All patients who were desaturating more than 80% over a period of 10 minutes were excluded. And the CPAP use, we know that CPAP has to be used for a minimum of 4 hours per night to get the vascular endpoints correct. The median for CPAP use was 3.3 hours. So it failed on all these three fronts, and then still the paper is being quoted, and same with the Recasta study that it does not reverse. Now the new study is coming on the Sleep Smart study, and I'm sure when these patients are included, you will have a remarkable effect on the people who have excessive daytime somnolence, who have marked desaturation, who will benefit from CPAP, and there will be a reversal of vascular endpoints.
Yeah, I think it's most important, like Dr. Joy has emphasized, that for all practicing neurologists or neurologists, acute neurology, chronic neurology, we need to ask this simple question about sleep. Ask one question and then it will lead you to other questions. And we can go on and on, but there is enough evidence now that there is a strong relationship between neurological disorders and sleep disorders. There's what we can say bidirectional, one makes the other worse, and treatment of one will improve the other. So I think it's just that we need to just be aware of it, wake up to it, and learn how to manage them. And I think then we can, take it forward. I thought that we could also ask the audience who's here with us today to give suggestions on topics. I agree that we kind of jumped right in and took on to very difficult cases. We've not gone through the routine or what we normally do in teaching, like we would say how to take a sleep history, what is a sleep study, what do you see in a sleep study, because we were not sure that what kind of the audience that we have. But please feel free to let us know that if you would like to start in that manner, we can go that manner. If you want case-based, we can do case-based. If you want one case and discuss that in great detail, we can do that. This was an introductory first time, so we thought this is the best way to start and get more input. Also, people are welcome to please participate. Joy and I took on this because we thought at least let's get it going. So anybody who has any suggestions, we are also open to what do you think should be the frequency? Is this the date and time? Is it okay? So all kinds of inputs are welcome, required, so that we can really encourage neurologists to become part of the specialty. So please do give it some thought, and people who are here, we look forward to receiving some inputs from you.
Yes, I think the whatever people who are participating today and perhaps others also can either write an email or they can send it to the IAN and it will be forwarded to us. So I'm sure that we can make the next meeting more meaningful, more engaging. I do think that we can always do one case. We may not do two cases each time. We can do one case because ultimately people love learning from patients, and then other discussions could be done in correlation with that case as well. So I think
some
someone's put
suggestions
in a
are
comment on the chat.
somebody saying cases plus teaching, okay. And somebody wants, I think, more interpretation. I also think that, we went into AHI and ODIs, and maybe people are not familiar with it. So maybe what we can do is do a case, and on that case, go deeper into some aspects of history and discuss the sleep study on that same case. What do you think?
Yes, it makes sense. I think we can do that.
Yeah. And because see, they're asking what is normal ODI, what is the interpretation of PSG. So I think maybe next time.
They are asking not because they don't understand. They're asking because it's a reflection of the dismal teaching that occurs in internal medicine and neurology. I know for sure that nobody's teaching sleep in neurology, and it is so sad. It is so sad.
It's a big chapter. It's like missing link. What about the frequency? How often should the frequency be?
Once in 2 months is good, or once in 6 weeks? What do people want?
I think 2 months is okay, maybe, because there are
2
lots
months
of
is
things
good, I
happening.
think. We could certainly do the next one in May.
Date and time?
I have some suggestion. What I feel is we need to increase the number of people, subsection members, one, so that we'll get good number of inputs. And second thing is once in 2 months should be fine. And along with that, maybe a case, along with that case discussion and the theory behind it. And technical aspects of sleep monitoring and sleep studies are very, very important, which we people lack significantly. And that's why we end up, we don't really see we just see most of the times people see the report and then it's not our case, let it go to a pulmonologist. That's what thing happen. But I feel, we need to learn the interpretation of the sleep studies. For that, we need some basics. So the
Okay.
case followed by, that would
Yeah,
be
so
better.
I think let's do one thing. Then before the case, let's do one on sleep studies. Because I think it'll get
What-
complicated. So see,
Yeah,
if we
let's
are talking
do
about
the next session.
hypersomnia, only on
Let-
sleep study.
Let's do one session, the next one, only on the assessment of sleep and interpreting the data accrued from a polysomnogram.
Yeah.
Yeah.
So I think we will do only
Let's do that one overview.
PSG. Yeah.
Then we can do cases again in the third meeting.
Yeah, because see, if we discuss hypersomnia and we jump to PSG and sleep latency, REM onset, MSLT, it is going to get very confusing.
Yeah.
So next one will be just sleep studies, the levels of sleep studies, types of sleep studies, indications for different types of sleep studies, and how
And
to
interpreting the data.
and interpretation of a
interpret
PSG report. Take.
Let's do that the next time. I think that's a good thing.
Yeah, because I think rather than, so that's what they are also, then it will help.
It will serve as a little primer for
Yeah.
everyone to get oriented, and then we can do cases the meeting after.
And Sunday 5 o'clock works for everybody?
Oh, it's a brilliant time. I think Sunday 5 is super. I'm very grateful that you wanted Sunday 5.
Yeah, okay. So I think so Sunday 5, and we can tell the team to announce the next date, and then we can at closer to the date we'll give them what we are going to talk on.
Yeah. Another point, as far as the stroke and the OAS is considered, the significant number of patients presenting with the refractory TIAs. Also, we need to consider this. We have investigated most of the etiology have been ruled out, but in patients who have continues to have a TIAs, this is an important differential
Yes.
which we usually neglect. So this is an important thing to find out.
Oh, absolutely. I had a big financier from one of the Morgan Stanley groups here.
Yeah.
And he had 3 DSAs done for recurrent TIAs. And every time nobody had taken his sleep history, and once he was proven sleep apneic and he was on PAP, his TIA stopped.
So I think
yes, we will.
Yeah, so I keep telling my patients that, so we look at all the risk factors and we go into the depth of keeping on chasing a risk factor, that why is this person having it again? But nobody's asked them that are they snoring?
Yeah.
So I think it's very important. Yes. I saw
The
one
best
other
part
patient
is
who has a Riles tube, and he said he's been snoring forever, and now because of the Riles tube, he's got severe sleep apnea and he's continuously spitting out. It was so uncomfortable, but it's almost impossible to now try and putting him on a PAP because he's at a great risk to have another one. So I think, yeah, that sounds good. So maybe we can end now, and any other inputs from the audience has been taken and received. So Joy, we'll do the next one in March, April, May, middle.
Yeah, May is good. I think we could do one in the first weekend of May, preferably on a Sunday at 5.
Yeah.
Let's fix that so that it's easy to remember.
Sleep study.
Super. Thank you everyone for being part of the webinar in the subsection. And it was great. Everyone participated. And thank you, Datta, Tarun, everybody else who have put in their questions and have taken interest in asking what came to their mind when they heard the stories. And it was really heartening. In the middle of the cases, we had about 41 people on board. So that's really nice.
How do we increase this? Is it the only neurologist, Indian Academy people only can become a subsection member, or anybody else can become any other specialty?
No, it is Indian.
Member of the IN first.
You have to be member of IAN first to become a member of the subsection. And when this subsection meeting happens, not only do subsection members get the mail, but every member of the IAN is also receiving a mail. So even if you're not a subsection member, you can still be a participant in the audience.
My other question was that suppose people are not members of IAN and not, we can ask that to the team, and not members of subsection, but they some other speciality, they want to listen to this webinar. They may not be that I would not able to understand. Can they or can they not?
Because ma'am, the emails won't go to them, na? Unless we have a public forum Zoom declaration.
So YouTube mein to hai, it's live on YouTube.
But I think participation on other specialties we should welcome, because sleep is a border zone area which all specialties get involved into it. So I think that we should
talk to the president and the digital team and ask them
Yeah.
So if we can see, so maybe not this one, but they have a live YouTube going on. So maybe we can share the YouTube link with the other people.
Okay.
Let's look into this. I think it's a good
Let's find
thought.
out. Yeah.
I think let's find out how the logistics will work. I'll also ask the digital team from IAN. They're all very cooperative. I must say, we must thank the IAN for putting together a very good
Yeah, the
network of
background
people
and
who are committed to making sure that the digital program occurs. And I must thank Asmita and Mansi both. I have been harassing them all these days. Thank you for being patient with me. It was our first time, so maybe I must have come across as being a little obsessive, but I promise to be less intrusive next time.
thank you for your help. Okay,
Thank
then
you.
I think have a good rest of the
Thank you.
Sunday and
Thank you.
thank
It was
you
a
again.
nice start.
Thank you.
It's a
Bye-bye.
nice start. Thank you. Bye.
Thank you.
Bye.
Thank you very much.